Today's lecture is on myocarditis. I did include an illustration that signifies the acute phase, subacute phase, and the chronic phase. And this example was really looking at a viral cause for myocarditis. We know that myocarditis is any pathologic process in which inflammation involving the myocardium is identified. The World Health Organization defines myocarditis as an inflammatory disease of the myocardium diagnosed by established histological, immunological, and immunochemical criteria. Epidemiologically, the actual incidence of myocarditis is unknown. And we do need to, though, recognize the distinction between cardiomyopathy and myocarditis, because often they are used interchangeably, but they should not be, because cardiomyopathy is any situation in which the myocardial systole or the diastolic function is impaired. And there's generally three categories, okay, types of cardiomyopathy: dilated, hypertrophic, or restrictive. So we do know that myocarditis accounts for about 10% of the cases of dilated cardiomyopathy. So make that distinction between myocarditis and cardiomyopathy and understand the relationship and why we don't have incidents that are accurate on myocarditis, so much as this is found post-mortem. And when you consider that most myocarditis is in a younger age population, then it's explanatory to a certain degree. The pathogenesis is it's a heterogeneous condition caused by a multitude of insults to the myocardium. It certainly can be infectious, such as a virus, a bacteria, protozoal, spirochetal, rickettsial, or fungal. But we also know that some toxins can cause myocarditis, such as alcohol, some chemotherapeutic drugs, drug-induced allergies, and autoimmune diseases such as lupus. And under the viral, I believe I read a statistic in your text that 50% of people with HIV on autopsy have myocarditis signs. Histologically, the diagnosis has to be made, a definitive diagnosis is made actually by a biopsy of the myocardium, but that doesn't occur very often because of the implications, okay? So we, on that biopsy, often we'll see lymphocytic, polymorphic, or eosinophilic indications of myocarditis. But we actually use other evidence, such as systemic and physical findings. But interesting, frequently, because we're not using the definitive EMB, the cause remains undetermined. Clinical manifestations really have a huge gamut. They can be from a mild fever, atypical chest pain, fatigue, possible transient ECG changes, which I share some on the last slide, to all the way to fatal cardiogenic shock and or arrhythmias and sudden death. Interesting, in Butera, they talk about if myocarditis progresses to systolic dysfunction, then those symptoms mimic left ventricular hypertrophy. If they progress to right ventricle, then you're going to see ankle swelling, loss of appetite, and bloating because of the fluid. More frequent, again, I mentioned this earlier, in a younger age group, although it can occur at any age. It may present subtle, so you must consider with any patient with symptoms of possible cardiac cause You've got to rule out other cardiac causes and consider myocarditis, even if there's a known cardiac condition. So kind of like a person or your patient has two things. They have known coronary artery disease, but they could be displaying the symptoms of myocarditis. And one way you differentiate that is that they don't have a typical presentation of their known disease, or what has happened to them in the past. It's just really making yourself think broadly and including this in your differential. Physical exam, you typically will see a resting tachycardia with an exaggerated chronotropic response in any exertion. Okay, so a mild case might not have any symptoms or a low-grade fever and tachycardia, but in the more severe cases, you really see the same findings, physical exam findings, as left ventricular dysfunction. You might auscultate a pericardial friction rub, and if it's the myocarditis progresses to right ventricular dysfunction, you are going to see that elevated jugular venous pressure, hepatic enlargement, right abdominal tenderness, pedal edema, ascites, and anascaria in severe cases. But be aware that patients with chronic heart failure may be symptomatic, but have few, if any, obvious physical findings. So think about that again. So an astute clinician would say, okay, my patients with chronic heart failure might have some symptoms of heart failure, but when I examine them, they will have, I really don't find any obvious physical findings, and that broadens your consideration of myocarditis. Diagnostically, I think I told you earlier, the EMB, that biopsy of the cardiac tissue is the only definitive diagnostic test for myocarditis, but it's not used very frequently. And then we also base our diagnosis, or more frequently, on clinical presentation with diagnostic testing. So the lab could include CBC with diff, ESR, CRP, those are those inflammatory markers, troponin, cardiac enzymes, IgM that progresses to IgG. We're always getting an ECG, an echocardiogram, and a cardiac MRI could be part of that diagnostic workup. Differential diagnoses. There's several, but I always like to think, as I'm teaching you and instructing you, think of the big three. Okay, it could in your diagnoses, is this an acute coronary syndrome, cardiomyopathies, and then a pulmonary embolism. Management is pretty simple and straightforward. Immediate specialist referral for all suspected cases of myocarditis. If you can't get them into an immediate specialist, they go to the ER. Patient and family education. Really, our responsibility is to relate what is myocarditis, and that it is a potentially life-threatening disease, and we must educate them on the process. It does affect the cardiac function, and there are multiple possible complications. So that patient that has subtle findings might not be as easy to convince that they need immediate hospitalization. But remember, myocarditis can progress rapidly and really can be the cause of cardiac demise. Thank you.